For the past 8 years, the All Kenyan Moot competition has been keen on pushing the conversation on human rights within the Kenyan context. Through conducting various moot competitions centered around human rights issues happening in Kenya, we've been able to engage with various stakeholders and, most importantly, law students from across the various universities countrywide to steer human rights discussions among students. This year will not be any different. Even with the COVID-19 pandemic that has changed what would be the old order to what is the new normal, we will hold our conference and moot court competitions to push the conversation around health and corruption, with a key focus on the Article 43 right, its realization, government response to the COVID-19 pandemic, and the malignant cancer of corruption that has over the years crippled the Kenyan healthcare sector. Join us virtually from the 2nd to the 5th of June 2021 as we discuss the theme, Combating Corruption in the Attainment of the Highest Attainable Standard of Health. All are welcome.
To welcome everybody to Kenyatta University and to Kenyatta University School of Law, and thank you for joining us for this 9th edition of the All Kenyan Moot Court competition. This is the 9th time that the competition is running, and we appreciate that it is because of partnerships that we have had with other law schools, with other stakeholders, depending on the theme, and even stakeholders who've been with us throughout, that then the competition has been able to run through the years. So again, we want to thank you for that. Yes, and to welcome you to this online session, and to hope that the discussions that we're going to have will be beneficial for our country and also for law students throughout this country. My other task is to do a small sort of a lecture to introduce or set the scene for the conference and also the competition. And I'm not going to take a lot of time to do that, because I do acknowledge and appreciate that our partners this morning are actually people with a lot of technical and practical expertise. So for me, I will only make very brief comments on the theme, which is combating corruption in the provision of the highest attainable standard of healthcare in Kenya. And to start with, when we look at this theme, of course, there is the right to health, the highest attainable standard of health. And when we talk about the right to health, we do know that it is a constitutional right under Article 43, meaning that it is justiciable and Kenyans can go to court and agitate or ask or petition when there has been a violation. And Kenya is also a signatory to international instruments, the Covenant on Economic, Social and Cultural Rights, and also the African Charter on Human and People's Rights, that do provide for the right to health. And I'm also happy to note that the governor in charge of the Committee on Health, Hospital Ojamong, is also with us this morning, and he too will be able to talk about the obligation of the county government as far as health is concerned. So for me, coming from academia, mine is just to say that the core elements of the right to health is about availability. They're actually four: it's availability, it's accessibility, acceptability, and also quality. In terms of availability, we are really talking about making sure that health services, health facilities, and also drugs are available. So drugs, medical personnel, and also actual physical facilities. And then the question of accessibility is mainly about non-discrimination, ensuring that everybody can access the right to health and taking care of marginalized groups, women, children, adolescents, and also indigenous people and other forms of minorities, including people who are in the bracket of extreme poverty. Then there is also the question of acceptability, that these health services, these health facilities, and also the health services, the health facilities, they also must be culturally acceptable, and they must uphold the dignity of Kenyans whenever Kenyans access them. And then finally, the issue of quality. Again, as I said, I'm not going to talk about the practical aspects because we have experts who will dwell on that. But we do know that governments often say that the right to health is progressive. Even our own constitution does provide that in Article 21 and also Article 43, that these are to be achieved progressively. But when we talk about progressive realization, it doesn't mean that the government should just sit back and do nothing. There's a certain minimum core obligation that the government is supposed to meet. And again, in the context of COVID-19, we'll be talking about ensuring that the health facilities, the services, and the goods are accessible in a non-discriminatory manner. We are also talking about availability of essential food that is nutritionally safe and adequate, so that to ensure that the right to health is not violated in that context. And then we'll be talking about adequate water and sanitation, and we'll also be talking about provision of essential drugs that have from time to time been defined by WHO as essential drugs. And that also brings into context the other diseases in the context of COVID-19, what happened to them? Were Kenyans still able to enjoy, or what's happening to them? Are Kenyans still able to enjoy the right to health in the context of those other, diseases other than COVID-19? And then, of course, the question of equity in the distribution of health facilities and also services and drugs. And again, going back to the theme of the conference, there is the issue of corruption. And we do know that the problem with corruption is that it does have an effect on the state being able to meet its obligations to respect, to protect, to fulfill, and also promote. When we have corruption, then the government is not able to meet those obligations. And it also has an effect on availability and accessibility, and also the quality of health services. Again, we're going to be having discussions on that. There's even a victim who is going to share with us her experience through the health system, and we'll be able to see the effect of corruption on those. And even in the context of access to health facilities, health services by individuals, whenever there is the question of a bribe, then access becomes difficult. And for Kenyans, there has also been reports about theft and embezzlement of funds in the context of COVID-19, and even the question of management of data, misinformation. We do know that one of the core elements of the right to health is accessibility of information. So if the information that is given is not accurate, how does that impact the right to health in terms of Kenyans being able to know what actions to take in the context of COVID-19? And finally, I just want to make a final comment on the indivisibility, interdependence, interconnectedness, and interrelatedness of rights, and say that whenever there's a violation of the right to health, there are other many rights that will then be violated, and we've been able to see that in the context of COVID-19. There has been people who have been pushed lower into the poverty bracket because of COVID-19. The right to social security also has been violated. Of course, a lot of people have lost life, so the right to life, and also non-discrimination and equality, mainly coming from the aspect of privatization of health services or the right to health, and also the question of corruption. So with that, I believe that I have set some sort of pace for the conference, and I will end it there. And once again, welcome to the conference, and thank you very much for joining us.
What does this mean for the ordinary mwananchi, for Kenyans today who still have to raise money within their families whenever they get sick, risk catastrophic financial risk every time they are sick, and possibly have been struggling in the last 1 year trying to prevent getting COVID-19, and also trying to continue with their livelihoods to ensure that they can survive. So I'll hand over to Matthias, who's going to start the questioning.
The Right Honorable Governor Sospita Jamong, for the first question to you. On a scale of 1 to 5, 1 being poor and 5 being excellent, how would you rate the government of Kenya performance in ensuring the right to the high sustainable standards of health to the local Mwananchi?
If you give an example of Busia County, for instance, you'll find that our budget in the health sector is 7.6 billion. But what the county can only allocate is around 1.5 billion. So the rest is being taken by the donor community, which are slowly and progressively withdrawing. So eventually, and our budgets keep on reducing. So you'll find that once the donors withdraw, you'll find that the health health services will drastically drop.
So thank you for highlighting those very key issues in terms of where you feel the government has done well and where you feel there's still improvement to be done. I would like to front a question to Dr. Ruth Laibon following this. Dr. Honorable Ojamong has mentioned the issue of health financing, and we currently find ourselves at an impasse with the US government when it comes to ARV treatment or ARV medication in this country, because we haven't reached consensus on how taxation should take place, and if taxation should take place, who the who the person procuring the medication should be and who should distribute it. And we don't know what is the position of the National AIDS Control Council on this, and how do we continue to rely on donors to provide medication for 1.6 million people in this country who require HIV treatment when we clearly don't have the finances domestically to do so. Honorable Ojambang has mentioned over 70% of what's happening in Busia County comes from donor funding. How do we deal with such impasses in the future?
So your question is around the funding for ARVs in this country and the challenges that we recently experienced. Allow me to begin by saying that one of the key issues we have with HIV is that it is a condition that usually require a convergence between citizens and government. Because on one hand, where governments are supposed to provide services, HIV itself also requires the cooperation of citizens to address. So the previous speaker, Honorable Hospital Ojamong, has just rightly said that for over the years, since the emergence of HIV in 1984, we as a country have relied on donors to provide treatment. Currently, per year, it costs Kenya around 25 billion Kenya shillings to buy HIV commodities and ARVs. We have around 1.2 million people living with HIV in this country. So what does that mean? It means that when Kenya was shifted from a low-income country to a lower middle-income country, something is about to happen within the donor and external alliance of funding. One of the things that happens is that you're moved from grants to what you call concessionary loans, or loans that you have to pay interest. So a lot of countries begin shifting away from countries whose economy is doing better than other countries. Issues such as money required for counterpart financing begin to also affect the way donor funding is provided to the country. So with that in mind, that Kenya was then rebased, the economy was rebased, it is important for us to anticipate that moving forward, we shall have more and more of these conditionalities. You did mention on the current crisis that we had on ARVs. This was because one of the second largest, or one of the largest donors had an issue with procurement and distribution of the ARVs. But that is just a pointer to what is a bigger problem. With 1.2 million people living with HIV, we have to be visible, or we have to have the visibility of these drugs. And the only way to have that visibility is that we need to be able to have exchequer money that is funding these drugs, because the challenge of interruption of treatment for people living with HIV is high. So what are we doing as a National AIDS Control Council? First of all, we've had to have discussion with the donor and look at the legal frameworks. There are things that you cannot change, especially acts of parliament in a country. So those discussions are ongoing and they are fruitful discussion. We have currently come into some form of agreement. The other element we are looking at is how else will we be able to sustain this response going forward? One is we are looking at the element of local manufacturing. Because then that way we can sustain, we can be able to deal away with a lot of expenditures, especially the ones for shipping. We can also be able to create jobs through local manufacturing. With the kind of epidemic, Kenya has 1.5 million people currently living with HIV, although we've only identified 1.2 million. You realize that sustaining these people for life on treatment, it shall require a lot of resources. And we may not be able to afford if we are relying on the current methodologies we are using to procure and sustain people on treatment. So one of the things is the local manufacturing. The other element we also are looking at is also efficiency gains. What can we do differently? And the other element is also stopping HIV infections, especially among young people, because you cannot sustain an epidemic when the tap is flowing. So we need to stop HIV infections from young people. If every year we have 41,000 infections, and out of these 61% are from young people, what does it tell us? By the time we fund these young people, or we buy the treatment for young people to the average number of years of life expectancy in this Kenya, around 67 years, it means that we need to pay more. It's like a mortgage. So we need to be very strategic, stop new infections among children and young people, because that is the only way that we are going to be able to maintain the current cohort we have of people living with HIV on treatment at a lower tax payers effort. So I think for the National AIDS Control Council, while we are looking at the immediate solution, we're also looking at what can we do as a country different. And those are some of the ideas that have come and are already in progress, and this is how we're going to deal with it. In terms of what we have currently, the drugs, we have drugs within the facilities. And as I just alluded earlier, we are actually reaching to some form of consensus that moving forward, we shall not have this situation reoccurring in the future. Thank you.
Thank you for that response. I'd like to rope in Agri Aluso from the Open Society Initiative for East Africa. And this question purely speaks to special interest groups in the country. We find ourselves living in a very interesting time of this pandemic, and I just wanted to get your thoughts. Have the interest of persons with disabilities or persons of the LGBTIQA community been protected by the government during this pandemic?
So yeah, so generally, I think you had asked me a question about there was a question that that is very, very pertinent, and I think it's been talked to. But I just wanted to lend my voice, in terms of what government is doing, in terms of policy development and advocacy for scaling up health programs, but also just, the question of the fight, fighting corruption in the health sector, which I think is an endemic thing, as all the presenters have talked about. I think health has been emphasized enough by panelists starting from Nerima and the governor, really putting forward very important point, and Dr. Ruth Masha emphasizing that health is a very critical entitlement for everybody in this country, and it's a constitutional and justifiable right that we should have. It should be progressively available to us, and not just progressive for the tokenistic show of effort, but progressive realization, with clear demonstration that all best available resources are being put towards, attainment of health as a right. But I think the governor was very candid and pointed out that we are not there, and there's no demonstrable. Effort in terms of government financing efforts, because I think that's where we'll be seeing, tangible efforts in terms of how much government is putting towards health. And he said that about 70% of funds that are available for the health service provision come from external sources, which is a very precarious situation we find ourselves in. And I think Dr. Ruth Masha talked about the HIV situation, where we recently had a very unfortunate spat with the USAID, or the US government, where they are putting very many unsavory conditions, which just shows that we don't have what we claim to be our, the actual sovereignty as citizens of a country. It was very embarrassing, so to speak. And I think COVID has really exposed us, the soft underbelly of this externally funded health services. And just to say that I think this dependency has been the problem that has brought about the lack of accountability in the health sector, because we have a social contract with our government for fulfillment of certain critical rights like health. But when you have this critical service being provided by external sources, you don't have the mandate to question USAID government or PEPFAR or Global Fund if they choose to change their priorities. And the governor mentioned that we are shifting. The donors are shifting priorities. We've been categorized as a low-income country, lower middle-income country, and therefore the loans have become, the grants that used to come traditionally have become loans. And of course, we've seen a very consistent shift more focus being given to private sector than public sector, leaving a large category of the Kenyan population without access to the critical health rights. As we speak, about 27% of the health expenses are met from out of pocket, pushing many Kenyans to catastrophic health expenditures, which means the people who, me and you, who may have health cover are much better off than the person in the village who has no health cover, because the public health facilities we are supposed to rely on mostly are dysfunctional, have challenges of commodities, have challenges of health staff, have challenges of infrastructure, and all basic commodities that should make our health system functional. So we've seen this consistent deterioration and lack of accountability in the health sector, which is a systemic problem that must be addressed. And I think that is a grand lack of accountability, and I'm happy to hear the governor appreciate that. So I just wanted to speak to that. And I think this, we've seen a very unfortunate reality that the health policy space is controlled by forces which are not elected, who have no accountability for citizenry. Most of them are business interests who influence health policy decision making. I'm sure all of you are aware of the managed equipment schemes, the famous MES, which was this grant scheme that was supposed to equip counties with the ICU equipment, with dialysis equipment, so on and so forth, which was eventually categorized or branded by the Senate Committee on Health as a criminal enterprise, which was designed to fleece. I think I'm actually trying to quote them, to fleece public of resources, critical resources, and that's just a tip of the iceberg. So we've seen such consistent scenarios where health sector is beholden to interests that are not pro-public interest, and they influence policies. They have access to policy-making spaces, and we've seen consistent, framing of issues as the most critical ones, and neglect of issues which should be helping citizens, for example, to avoid getting ill, not given priority. If you look at our UHC financing structure, you see that the amount that has been allocated for prevention is very little. The bulk of the resources are for curative. And why curative? Because curative is very pro-capitalist. So the neoliberal forces, the market-oriented forces, which direct our policy priorities towards, buying commodities, pharmaceutical sector, definitely having a great influence, and they do that everywhere. And we can see the consistency with which we have seen deterioration of primary healthcare and elevation of the curative, hospital-based healthcare, which require people money, as something that has really created a problem. And we've seen where that has taken us with COVID. We've seen how that has consistently created high burden of diseases which are preventable because we don't focus on the real thing. So for me, those are symptoms of corrupt system that has no commitment to fulfilling the essential right to citizens, as enshrined in the Constitution. Just to say that. So let me come back to the question you had asked me. So I think we've seen over time also consistent narrative that try to other, important critical members of the society. I think, Narima, when you're starting your opening remarks, you talked about Article 43, and I think everybody has talked about it. And I think there's also another article, should be Article 21 or something, that provides that there should be non-discrimination. The government, you can correct me, I'm not a lawyer, but I know there's a provisional provision that provides for non-discrimination of anybody on any basis. There is no fathomable ground for exclusion towards realization of rights by anybody, whether you are a thief, whether you are disabled, whether you are LGBTI. The Constitution does not envisage a scenario where somebody should not enjoy certain rights, unless you now have to die because you've committed a capital offense. But when you're alive, you're entitled to those rights. Yet we've seen consistent neglect of certain critical populations who actually require a lot of health support, missing out totally from our, policy, making spaces in terms of them being a focus of those policies or them being included in the policies that are targeting everyone. And these are, results of very endemic, discriminating narratives that stigmatize and exclude certain populations based on what is perceived to be the normal And I think we really have a duty to remain, to remain loyal and exhibit fidelity to our constitution by ensuring that the law is inclusive and the policies are inclusive and the services are inclusive for all segments of population, be they LGBTI, be they sex workers, be they people with disability, because we are all human at the end of the day, and moral, judgment notwithstanding, we don't lose our humanity or our humanness, so to speak. So I think that's somewhere we still have a lot of work to do, and I'm glad there are officials from Ministry of Health who are here, but we've seen good progress. Like the National AIDS Control Council, I think, has been very consistent in ensuring that they're included in the HIV programming. And I know particularly Dr. Luth Laibon is very committed to ensuring that key populations are not missed out in these critical services that they are disproportionately affected on. Thank you.
Thank you so much, Mr. Luso. And the article is Article 27 on non-discrimination. But so let me rope in Dr. Bernard Langat from AMREF, really on the role of private sector, and I hope you can hear me. So Dr. Laibon mentioned local manufacturing for ARVs in future. And one of the largest questions that we've had around this pandemic is what is the role of private sector and the role and the obligation of private sector in the management of a public health crisis, particularly with the discussions on vaccine equity, the role of pharmaceutical companies, the issues around intellectual property, patents, trademarks. Also, with many issues that came within our country at the beginning of the pandemic, many insurance companies refused to cover COVID at the beginning of the pandemic and only started to adjust their tone maybe 3 to 4 months into the pandemic. Hotels were used as mandatory quarantine centers, usually at exorbitant prices for the people who've been asked to quarantine. So really, what can be considered the role of private sector in facilitating access to healthcare services and within a public health crisis such as the COVID-19 pandemic?
Well, thank you very much, Narim. I don't know whether you can hear me.
Can.
Well, yeah, the private sector is a diverse group. So I think let me start with that because we'll classify the for-profit private sector. We have the NGO or the civil society component, and we also have the faith sector. So that is it, especially at the service delivery point. Yeah, but you can also expand the private sector to manufacturing, the distributors, the wholesalers, the providers of maybe the consumer goods, which is really critical during the COVID response. So probably as in answering your question, I may want to probably speak into those different categories. And to start with, especially in the service provision and the COVID response, I think as a country and kudos to the Ministry of Health, at the beginning of this pandemic, they actually reach out to the private sector, especially the NGO and the faith-based sector, and they are members of the COVID task force. They actually supported even different thematic areas. The recognition, of course, that civil society is very strong at the community level, and actually leadership was provided by the civil society organization. One case is that Ambref, you're actually leading that, and Kenya Red Cross also came in when it came to mental health. So really, I think for me is that that recognition that we can only respond to COVID together, whether you are private or public. I think that was critical, and we did see the private sector mobilizing resources. I mean, there are quite a lot significant resources channeled through this private sector from traditional donors, from the foundations, and even some of the bilateral donors, and of course that ultra kind of approach where you channel resources through government and you channel through the private sector ensures that any marginalized group or pockets that are not traditionally reached by the public interventions will be able to be reached. And I think that recognition also is critical. I think Oluso mentioned the out-of-pocket expenditure, but I think it's important to know that probably the private sector covers close to 50%, 48% of service provision. I think the last Kenya held expenditure utilization survey actually put it at done in 2018, put it at 48%. Unfortunately, also of course, is that it comes to a cost to the household because 25% are still being out of pocket. There are no prepayment schemes. So then when you go to the private sector, then you will see that the cost of delivery of the services get magnified, and we hear people definitely complain about the cost of accessing services. And that speaks to the idea that we really need to think deeply around UHC and setting up a good prepayment schemes that is able to caution the population so that when they go to the private sector and they're seeking services, they don't have to pay out of pocket. Now, when it comes to manufacturing, of course, I mean, COVID has just highlighted we are importing sanitizers, masks, but I think there's been a great shift and a lot of people are now manufacturing things like sanitizers, you know, even government institution masks. We have seen for private and government institution making reusable masks, surgical masks. And I think that really at the beginning when we came in, the prices were exorbitant. I mean, you are paying 3-4 times the normal cost for some of these PPEs. And really that cost is either transferred to the patient, or it means that with the little money that we have, we are unable to really provide adequate coverage. And I think with the local manufacturing, we see prices coming down, and of course the supply chain disruption has gone down. So I think that is something we need to encourage. And I know you mentioned the issue of vaccine manufacturing. There was a big meeting recently guided by the AU looking into vaccine manufacturing. Yeah, of course, we are focusing at COVID, but we know that even all the childhood immunization is still 100% imported. So yeah, we need to go for local manufacturing, but then it is critical that we also invest in related infrastructure and the soft skills that are required for that. So do we have the adequate human resources to do that? Do we have an enabling environment? I mean, this you can manufacture, but the cost of that product, because you are not giving incentives, is very expensive, and therefore even when you go to the market, you are not competitive. And we have seen that even for anti-malarials, that the cost still remains high for some of the locally sourced products. We have seen some of multinationals shifting out of Kenya to Egypt to go and manufacture. So as we think about local manufacturing, I think it goes with incentives that is required to make sure that we remain competitive. It's not just manufacturing, but we have to be competitive, and I think that shift and it requires political commitment, you know, not just the rhetoric, and that if the government must be deliberate in supporting local manufacturing, and even academias and institutions must also be deliberate in investing some of the researchers that they do. I mean, if you go to universities, a lot of the research is focused towards achieving your master's, your PhD, but really we need to make sure that some of the research that our students are undertaking is geared towards either developing products that can then be commercialized, or it addresses the needs and the challenges that is facing the health sector. Maybe in closing, you mentioned the question of insurance. Yeah, I know it was a bit of challenge. They are covered by pandemic. I think there's a clause that they normally don't cover pandemics. I know IRA came in, and but it really we didn't see traction. Some companies actually had to mobilize resources and provide their own alternative. So yeah, I think probably is a conversation that we need to have with the insurance providers. But also remember our insurance space is quite small. So and really what we need is the big player to level that field, and the National Health Insurance Fund, probably if it is reformed as a social health insurance, that probably will be the game changer. But of course, we must invest in governance, and we must invest in building the confidence of the population that their money is safe and there's fairness. I mean, if you look at the payments that the public sector actually suffers a lot. The people who really get a lot of the support or claims is from the private sector, and not the public sector. So I think sometimes also speaking on the other side of the public sector, which ideally we should build, I think there should be some element of reforms that ensures that you get rebates that commensurate to the quality of the services that you get. I think that is it for me. Over to you, Narima.
Okay, we have Salim on the call, and thank you for joining us. As a consumer of healthcare services in the country, what has your experience been accessing these health services?
Thank you so much, Matthias. It's a pleasure to be here and echo all the sentiments made by other panelists. To be very honest, as a consumer, and actually more so during the recent time that I was sick, down with COVID, the experience was not so good. First and foremost, what people want to have is services, bottom line. Whether we get money from donors or whether we get money from the county or the national service, all what we want are services because we are taxpayers and we are citizens of this country. So it was not so good of an experience. First and foremost, just to mention that most of all the drugs, and I think even at the pharmacy, I think they were either doubled or tripled. And even the fact that you are supposed to have them maybe for 14 days, that meant also that you had to eat well, rest well. All this was at my costs. I think what the government did or missed was to treat the health crisis as a security crisis. So even the fear and the victimization and the discrimination that came with that. So everyone, when they heard that you are a COVID patient, because of the fast scare that the government made publicly, it was treated like a security crisis and not a health crisis. So wherever you will go, even to seek for those services, people will treat you, as if you're dying the next day, or they're gonna contract the virus from you. So it was not so of a good experience. And let me say, the way our health infrastructure is currently, and the way people had thought that so many people will die from that. I think for me, and I respect what Honorable Ojamong said, that he rated the government 3. If I were to rate the government, I'll give them a 1, because they didn't do so well. Even when we imposed the curfew and all other measures, what were they doing to mitigate that? And more so to the people who lived below $1, or people who live in the informal settlements. So I think that is for me now. Thank you.
Thank you so much, Salima. And thank you for sharing your experiences with us. I would like to then turn to Dr. Laibon, particularly given your extensive experience with the HIV epidemic. What lessons can we learn from how we manage that epidemic within this country, and how can we utilize those lessons going forward with the COVID-19 pandemic so as not to make some of the initial mistakes that we made with HIV, such as stigma, discrimination, continued placement of responsibility on individuals rather than considering it a crisis that needed to be governed and managed publicly?
Let me just say that one of the lessons, or some of the key lessons that both COVID-19 share with HIV is that both are critical junctures, meaning that they redefine not just a country health architecture, but the entire world. So the emergence of HIV, similarly to the emergence of COVID-19, shifted quite some ground across the world. The other one is what I mentioned before, that prevention and control of this kind of pandemics depend on the cooperation of governments and citizens. And the third one is that for the level of magnitude you see such pandemic like HIV or COVID-19, the badly designed responses are likely to place a country in a crisis. And we've seen that not just in Kenya, across the continent, where countries have gone through a deeply negative pathway as they try to deal with the epidemic, the magnitude of COVID-19. The other element, which has just been alluded previously, is the fact that this kind of diseases like HIV lesson has taught us, they have a way of affecting people living with HIV more. They become more vulnerable. If you look at HIV, it now currently start to follow the pathways of poverty. Poverty in the sense that even where rich people get HIV, they are able to access their medication in good time. They are able to get that transport that is required. If you look at COVID-19, the requirement of things like mask, sanitizer, people not living in crowded places, already that is a disease that starts defining itself along the pathways of inequalities. The other element is women, and especially poor women and girls, who then begin to suffer the burden and the disproportionate burden of the disease such as HIV as well as COVID-19. If you look at COVID-19, the burden of care, who are the frontline workers? Majority of our nurses or the workers are women by design. If you look at the lockdown situation, what we experienced, teenage pregnancy, women living with abusive partners within those crowded situations, and you begin to see women also being the majority when you come to the lower jobs where people closed and actually send people away. You know, you look at the mama mboga who is not able to sell the mbogas, majority are women. So you begin to see that indeed these diseases then begin to show you another pathway that you may not have thought about as you create your health system. But the most important one is that they both present an opportunity to strengthen the health and community system, because it's a crisis, and therefore as people deal with crisis, they begin to start asking ourselves, what are some of the things that we can do differently? What are some of the lessons that we're learning? So in the perspective of the HIV sector, we as a country have been applauded for having really responded very well. One of the things that happened early on, immediately COVID-19 kicked in, the country was able to sit down and become one of the first countries to actually do HIV response in the context of COVID-19, basically putting our policies, looking at what shall be done differently. So way before the lockdown, one of the things that was done was multi-month dispensation, where patients will be given more drugs. They don't come back to the facility. Some are being given 3 months, others 6 months, depending on case to case. This was able to also just make sure that we don't have congestion within the health facilities, because there are same health facilities where people are coming for ARVs. And as I said earlier, Kenya is one of the high burden countries. So if you have HIV, TB, and malaria, then you realize that your system is jammed. I also want to really say that the government of Kenya tried very, very much to ensure there was no disruption of HIV services. I also want to say that the partners that were on board, especially civil society and communities, Aluso did mention the power communities. One of the communities that we can really applaud is the community that serve marginalized community like key population. Some of them were able to come with very innovative ways, including door-to-door, taking commodities to their constituents. So we know that Kenya is usually very good at dealing with crisis. So we have learned that some of the lessons that we learned within HIV could also have been applied to COVID-19. The previous speaker alluded to the fact that there was stigma. So what causes stigma? Fear. What causes fear? Unknown. People don't know. They don't know what's going next. There's no treatment. So just like what happened with HIV, we had already learned the lessons. For example, we knew that at the beginning of HIV, messages such as the burial procedures where we saw people being put in polythene bags really created stigma. We also knew HIV messages around pictures that were showing people in their weakest moment and vulnerability created more anguish and fear. I know some of the new generation may never have seen those pictures, but those are pictures that then led to high stigma levels. And I want to look at how we manage disease in Africa as compared to the West. I happened to be out of the country when COVID-19 struck. And the first person who got COVID-19 I knew of was a colleague. But what did we do? The first thing is that people called. People went to his doorstep to take flowers or take some supplies. And there was that concern of moving towards the person. But when the first case came here, there was a tendency to run away from the person, and that's what creates stigma. So I think we had already learned the lessons because we spent a lot of money trying to destigmatize HIV, and therefore we cannot afford to stigmatize another pandemic to the magnitude of COVID-19. So that is one of the lessons that I think we need to quickly take up and apply it in the management of COVID-19. The other lesson is, in the end, you mentioned something around patent laws and all these laws that come with manufacturing of vaccines. This is one lesson you've learned from HIV. It took people living with HIV to actually go and camp within the United Nations to say and demand companies to drop those patent laws. It took people living with HIV to clamor for the TRIPS, and all these things that we enjoy today, including the generics. So what will it take for us to ensure that we are not being left behind during the COVID-19 discussions globally? We have to wake up. This is not just a government discussion. It is a discussion that as a country, we realize that whatever is happening in the level of Geneva, in the United States, in high level meetings, really affects us deeply. And then we begin to say that we need a vaccine for everyone. And this is a kind of pressure pharmaceuticals need. They need country pressure. They need citizens to come up and join government so that we can be able to demand and dismantle some of these legal perspectives that eventually come to harm the people. You're aware that right now there's a whole discussion talking about the vaccine inequality. Some countries, the UK, they have been able to vaccinate almost close to all their citizens. And now this is a discussion happening now. What happens to the countries like us, who do not know what happens with the patent? We also have not moved fast to develop our own vaccines. How do we then get into that center stage as we demand for those TRIPS, generics, whatever you need to demand for the vaccine to be for everyone? Then at the same time, even ourselves have funding our own localized solution. We are funding our own system of production where we should be able to say, we can actually, even if you give us that, we have factories ready. For example, let me just give an example of HIV drugs. The 25 billion we spend, a lot of that money goes where? Of course, it goes to companies that own the patent, but it goes to India because India is where most of the manufacturers are. And that employs young people in India. And here, that same money we are spending, if we had those factories here doing the local production, then that money then would have translated to some money being left within the economy and some people getting jobs. So in essence, we have major lessons learned that we cannot leave the management of our pandemic in the magnitude of HIV or COVID-19 to external people. We need to look at every single print that we are receiving, from the prints, from the discussions that are happening in the town halls of Geneva to the ones that in New York, to what is happening in Iraq. And we have to get interested in this conversation because the conversation out there then come back to haunt us later when we realize that even our own parliamentarians have not really been informed adequately. So when laws come, and one of the experience we had with HIV is like when these TRIPS came and the anti-counterfeit bill was in parliament, it took a lot of, a mobilization of citizens to actually tell them, this is, if you sign this law, this is what it affects as the bill as it is, this is what it will do to your citizen. So we have to look at how does the law and the laws within the medical field come back to haunt us, and how then do we move ahead of time to be able to ensure that people have the adequate information? So in essence, what I must say is that if I was to give the government of Kenya, I know one of the things that people were very complaining about was the lockdown. If you go to France now, there's something they call the Kenya lockdown, Why do they call it the Kenyan lockdown? People laughed at us. BBC laughed at us initially when there was the lockdown that was imposed with the time curfew. Right now, you go everywhere, people are saying lockdown. People stop moving from 6 p.m. At that time, it was a joke in Kenya. People thought, oh, does COVID only spread at night? Yes, what the government was trying to do is to look at the patterns of movement. When do people drop their guard? Somebody wears the mask the whole day, but as from 6, you meet a friend, and from there, then you become familiar and the mask is dropped down. So there are designs through leadership. And that's why for me, I would really looking at other countries, not just because I work for government, look at what Kenya has done so far, and I'll really give it a mark on COVID-19. Of course, there's a lot more that we could have done. And that could only have happened if we had the money and were paying for every single item so that we will know how to start remodeling our hospitals. And that is one of the critical things we've learned, that you can never have hospitals constructed with cylinders of oxygen. We need to pipe our hospitals, they have to be modern. And these are some of the things we are learning all the way, but we cannot continue learning and just not having a way of rectifying what we've learned so far. So over to you, and I hope that probably I've been able to answer that question adequately. Thank you.
Thank you so much, Dr. Laibon. That was more than adequate. I think we have Honorable Ojamong back. Welcome. And we apologize for the difficulties you're experiencing earlier. Well, since we have you, we were all very excited in 2010 when functions were devolved, particularly the health function. This was because the centralized health governance system had not worked for Kenyans for about 4 decades. So devolution was something that we looked at with a lot of excitement, inspiration, and really we're anticipating a lot of good things to come. And looking at what we've seen in the last decade, or at least the last 7 years since the functions were fully devolved to counties, we have had a lot of criticisms of how funds were being managed both at national and county level. And one of the key criticisms has been that corruption was devolved, but not really the function of providing health services, as we're seeing more and more corruption scandals coming from both levels of government, whereby we already know we're strained in providing financing for health and ensuring that our citizens can access healthcare services. Would you be able to speak a little bit about corruption in the health sector, particularly within a county lens?
Thank you very much. I hope you are hearing me well.
Yes, I am.
I think you are now becoming clear. Initially, we had challenges with the communication. Indeed, in 2010, when we developed the health sector, what we had in mind, especially those who participated in the crafting of the constitution, was that we are going to address the issue of health financing. But we just developed the function without taking care of the financing aspect. And as one of the first governors who came in when devolution came, was initiated in Kenya, what we insisted was, before you develop a function, it would have been proper that the technical team sits to unbundle a function and cost it, so that we know exactly what is the cost of running a function. How many ambulances does a county want? The essential drugs, healthcare staff, and all other things that are related to delivery of health services. That's what we insisted, because we wanted the function to address the function realistically. But unfortunately, everybody evaded. The Senate evaded it. The National Assembly also evaded it. And we have just been trying to use very techniques that cannot be applied to address the issue. So that's why, in fact, the issue was that the national government was just in a hurry to devolve all functions without looking at the financial aspects, health being one of them. Quite a number of functions were developed: health, agriculture, water, ECD. You know, those are functions that are very critical, that need a lot of attention and financing. It only remains with those functions that do not need a lot of financial, or that have no bearing to the people so much. So eventually we were given a function with no financing. In the case I gave you about Busia account, the salaries alone, it take up quite $1 billion. And then you remain with very little money to purchase the essential drugs and also to employ, to pay the salaries. It becomes very little. Like when we, as a county, you give 200 million for the purchase of drugs, it's not possible. So all along that, now that people believe that when we don't have drugs in the hospital, they say that's corruption. The money has been eaten. They don't know that you don't have the money. When you don't have enough health personnel, they will also assume that, oh, this money has been eaten at ABCD. But let me say, corruption in the health sector, might be emanates from the procurement, whereby it might be drugs are overpriced, but that has also been lessened because we have a standard price, the survey that is usually done, whereby every county has to refer to those prices and procure within those prices. So there's always that the prices that have been already surveyed, and it might be again, it's just in the procurement department where we have might be cases of corruption, and the disappearance of drugs from hospitals has been lessened because security has been beefed up. So I would just say that the personnel handling the health sector have also been improved. It's not like the casual ones that we used to have previously. So cases of corruption in the health sector might be the counties. Just led to loss of drugs through might be other ways that the personnel are unable to explain, and might be spending money, the money that is usually collected from hospitals on source. That's also because as you collect, you also spend it, and which the law does not allow. And we don't have the infrastructure maybe to capture that, because like the health, there was the FIF before the Facility Improvement Fund, which was there previously, where money paid in hospitals could be replowed back. But yes, but nowadays you pay, then it goes to Nairobi, then it's brought back after a very long time. So to me, the issue of corruption, it's not so much in the health sector, but the issue again about corruption might be is the health personnel, where we have a problem. You'll find that the main purpose of the function of the national government is to train the medical staff. So you'll find that without consultation with even the county governments, they can take even 10 doctors for training without consultation with the county governments. And then you deny the people the services from this health person, you don't replace them, and the county continues to pay them, and they go for 4 to 5 years, 6 years, and some of them do not come back. I find that also a very big issue, and that happens to doctors, the clinical officers, and also the nurses. So mine is just to say that other than what we witnessed recently during the COVID case, where money was actually lost in some counties, just because this was an emergency, might be, and some people took advantage of it. It was not to a greater magnitude, but we say that it was because of the emergency that people faced, that some money was misappropriated, but I think the Auditor General highlighted it, and the difficulties people faced were being addressed. So mine is just to say that failure by also the health personnel might be to render services to the people because of multiple interests in the counties they are. Some people have opened their laboratories, some people have opened their hospitals. And instead of concentrating in the public institutions they are employed to discharge their duties, they spend most of the time in their facilities. Then they just come to buy time when they come back to the, as I see that as also a form of corruption, which should be eliminated. These people should be made to concentrate in the facilities where they have been employed and to serve the public, and not to have parallel programs might be running there. I see that that's so much rampant, because this is what the doctors say, that they are on call. They are just in somewhere hiding, so that you call them whenever there is an incident instead of being available in the facility. And they have taken advantage of that, spending most of the time in their facilities. So I think that's my contribution. Over to you.
Thank you, Governor Jamong, for your contribution to the discussion. I'd like to rope in Dr. Bernard Lagat and get your thoughts on this. So we have a ready population to be vaccinated. We've seen the youth jumping the queue to get vaccinated while they're not at risk of getting the disease. But currently find ourselves in a space where we have a ready population, but with no doses of the vaccines. Is this a question of funding, or is it a question of lack of availability of the vaccines?
Yeah, thank you very much, Matthias, for that question. Yeah, at the beginning, of course, when we started the discussion around COVID, there was a lot of fear about vaccine hesitancy, and it's still a problem. It's still a problem. Yeah, people are ready and willing to come forward, but probably we need to follow the science. The science is that these vaccines protect you from severe cases. It doesn't protect you from getting infection, and normally suffer the severe cases. It is the elderly, the people with comorbidities. So I think even as the youth is trying to jump the queue, we really need to follow the science. That we don't want our hospitals to be inundated by severe cases that are presenting, requiring very expensive interventions. So that is one. So the youth have to wait, really, and we need to encourage that. Now, on the question of the supply, the bigger problem here is availability of the vaccines. If you look at the stream that we are waiting for, is the AstraZeneca through the COVAX, and mainly it is coming from the India Serum Institute, and of course the Indian government with the second wave, and really the impact on their population. They simply say you can't export until we are covered. So there is really a big problem of availability of the vaccines. I think through COVAX, the government anticipated to get almost 3 million doses, and we have just gotten slightly over 1 million doses, and that really becomes there. So this vaccine nationalism, and I think the message even from the Director General that we are not safe until everybody is safe is really critical. And I agree with Ruth Marshall that we need to take it to the civil society voices, the communities. We really have to take it up with the global community. Countries are already moving towards vaccinating the young people. Really, the benefit in terms of the benefit that they give to those young people vis-a-vis the losses that we'll see in the developing countries is really huge, and yeah, and something has to be done. So by and large, for Kenya is the question of availability. But as we move, the moment you start exhausting this targeted population, then we really need money. I mean, COVAX is probably availed through because of a joint partnership by different donors. But the moment you want to expand to, we are targeting almost 20% of our population. That definitely is a lot of money, and we have to see where to get it from. Of course, as a country, we have to go back to exchequer, and of course still engage with our partners and donors. So for me, I think just as a country, let's follow the science. The science tells us target the key vulnerable population before you start moving to the young people. Over to you, Matthias.
Thank you so much, Dr. Langat. I would just like to move to Mr. Aluso. I hope you're still with us. Just following from the conversation we just had with Honorable Ojamong, you do work within the development sector and you are one of our development partners as a country. And I would like to understand, does it cause any disquiet on your end or on the end of development partners when you hear about previous corruption scandals such as Gavi in 2016, the Global Fund in 2017, where we had independent audit reports, even from our Auditor General, indicating that there was massive corruption in the health sector. And we've had Senate committees as well as National Assembly health committees discussing this issue of corruption in the health sector. I think with one Senate health committee indicating that we have massive corruption and massive theft happening in broad daylight in our country at the expense of our people. Was with regards to the purchasing of equipment by the national government on behalf of county governments. So from your perspective, does it cause any disquiet investing in Kenya, considering you have continued to invest in the country, understanding that there are some issues around corruption?
Thank you, Narima. Absolutely, this is, I think this is the exact problem statement with our health system, which I had alluded to earlier. I think corruption in Kenya is so endemic at the level of permissiveness. It's worrying, and I think there's quite a very worrying pattern, as you rightfully say, that we've not seen, consistent action despite overwhelming evidences in many instances where, people have actually been made to be accountable for corrupt, for corrupt practices. And I think one thing we have seen consistently also is certain sectors are more vulnerable to corruption. The health sector happens to be one of them. And what we are seeing recently, we've done a lot of studies, even trying to gauge public perception around corruption. Other than the fact that it's hugely permissive, the value system is so allowing, and people are so demobilized around pursuing corruption-related cases. It is inherently an area that has very low political weight. We don't see people organizing. You see in Kenya, when a road is bad, people mobilize and even hold protests and plant bananas on the road. And we've seen even the recent past, you heard of cases where police had to violently disperse groups of people who were protesting. In various, at any given point, you'd hear such. You rarely hear of instances where a woman has traversed 10 hospitals. There was a case in Homa Bay County, and there's so many of them I think that we've heard about. But a documented case in Homa Bay where somebody was, can you hear me? Hello?
Yeah, we can hear you.
Okay, sorry. I think everybody just froze and I thought I couldn't be heard. So yeah, a case where somebody had to be ferried around from one facility to the other because one facility after a public facility after the next do not have essential services. And eventually the person succumbs and there's no public anger. So I would just say corruption has become normalized, unfortunately, in certain sector because of the low political weight, and the health sector is one such sector where we've seen so many corruptions. And the governor talked about, the health workers also being part of the problem, where they have these moonlighting businesses where they operate parallel facilities. I think dual practice, unfortunately, the policy in Kenya still allows dual practice, and it's inherently problematic. Other countries have had to deal with that, but we still allow people to practice, in public facilities, and it's a last resort for them because I think the conditions for working. Some of them said in certain, in certain engagement that we had with them, that sometimes they just feel bad because they preside over a sick system. The health system is sick. They literally sometimes just have to sign death certificates because you want to help and there are no tools to help you manage those situations. They're always running short of critical, essential commodities, health commodities, and they don't have, those infrastructure that would help them manage even simple conditions. So Narima, it's true. We've had very many high-ranking, very, very high-profile corruption cases. We are yet to see, any exemplary action taken against such cases, and that just creates a permissive system that the next person does not see a reason why they should not engage in these processes. And in as much as you'd want to blame the health worker who knows there is money allocated, for these essential commodities, and it has been diverted somewhere. Counties have been accused of diverting critical resources from the health budget to non-essential issues. I have been told by health workers, we work with them very closely, that in most health facilities within the counties, you'd find non-health workers outnumbering the health workers within that facility, because people are being rewarded for political loyalty or for other reasons other than the fact that the service to be delivered. So those, just create a negative precedence where everybody feels like the way out in this sector is to just do your own business or to divert the little resources that are there. So I think the system has been so enabling for corruption, and the judiciary has not been able to deal with it, because I think those who are meant to be supporting the judiciary but may deal with these cases, like the investigation, either the oversight committees in parliament or the investigating bodies, have not been able to table any tangible evidence. Like you saw what happened with the Senate committee report on MES, which with all the evidences, and we know we've also done some studies, and we know, for example, there was no consultative process, and governors at one point protested that there was no consultative process as the devolution protocol requires. We are not sure that the issues which were being funded were the priority issues, and clearly you would see certain factors other than public interest were driving the investments, other than the real needs for different counties. Different counties have different needs. They can't have blanket need for either ICU equipment or theater equipment or whatever it is. The devolution principle requires that each county is supposed to provide their priority based on the need that is in that county. There's no evidence that there was such a process that informed, for example, the decision that was reached to procure certain types of equipment to be distributed to different counties. And we've seen that locking up significant resources from those counties, for example, this something that violates the whole protocol around devolution, where the resources are supposed to go to the counties, and then the counties are supposed to make decisions. But you find significant amount of these resources were actually being retained at the central government, by the national government, to pay off these suppliers. And we know about those as well. So we've heard about the corrupt cases like the Gavi, which I know Colleen is pursuing, where money was actually refunded because the government officers could not account for it. Yet we cannot even be told where did the budget, who approved this budget for refunding this money? Which budget line is that? And what action was taken by government to recover that money? Yet it is very simple, just do a trail of this whole simple process and just go back to the person who was responsible. So we don't see political will in fighting corruption in this sector. And I think the lack of government significant involvement in health sector, where there's been consistent framing of health as a charitable act. I think this is the most disempowering element within the health sector, where people have eventually internalized the fact that health is an individual endeavor. So if I fail to secure health, either through insurance or being able to pay, it's my personal failure. So there's no collectivization, or there's no collective engagement in pursuing accountability in health, because you perceive it as something that was given to you as a charitable act, as a charitable gesture. And that's how it has been framed deliberately by people who don't want to promote accountability. And that is so endemic that we don't see any anger. The lack of anger, like the one you see when a motorcyclist is knocked down, you don't see it in health when people die, and so many people die in health, avoidable, preventable death. So I want to conclude by saying I think there's quite a lot that needs to be done. The law will remain there as long as there's a framework, there's a political environment for implementation of that law. But I think citizens need to really wake up to this responsibility that they have, that we have beyond just casting our votes, also the responsibility to ensure that the essential critical rights that we are entitled to are accorded to us, and there is no reason why they shouldn't be. I know WHO has very clear stipulations in terms of the investments that are necessary for a developing country like Kenya. I think it should be about 5% of our GDP should be allocated to health. I think we are less than 1%. Or the per capita allocation, where individual citizens should have commensurate amount. The initial first step, even the Abuja declaration of 15% of our total general government expenditure being allocated to health, we are always around 7%, 5% thereabout. And the bulk of what is allocated is wasted. And therefore we have very critical failures, in very essential components of health, just because we don't have a system that is people owned. We have a system that is foreign backed, and I think that's what we need to push against and mobilize ourselves to be able to hold these duty bearers accountable. Thank you.
Thank you so much, Agri, for that very extensive answer. I'd like to move over to Honorable Ojamong. We note that we started a bit late, so he does have another engagement that he needs to attend to. So I'd like to allow him this opportunity to both give us closing remarks and answer this final question before he leaves us. So we'd like to thank you very much for your participation, and we know that you have another engagement you need to attend to. So we wanted to ask before you leave for you to give us closing remarks, but also to let us know a little bit about the universal health coverage. Given that the president's term ends at the end of next year, and this was part of the political promise of the re-election in 2017, we have seen the pilot program in 4 counties. We've seen Makueni undertake their own UHC project by themselves. What do you think is next for UHC? We no longer have the political backing. It's really fallen very low on the priority agenda for this government, given the pandemic and the BBI initiative. We haven't heard as much about UHC in the last few months. We even haven't heard much about what happened with the 4 pilot counties, how well they were doing, how poorly they were doing. But we do see it as a possible route to access health services for many Kenyans. Do we see this as a sustainable solution to realizing Article 43(1)(a)? And if so, what are the challenges we faced so far, and how can we address them in future?
I think the initiative for universal health coverage was a very good one, of which as county governments, we gave out around 5 counties where we wanted to experiment whether it can work. But so far, the results indicate that, after our discussion, that universal health coverage has not worked out so well. It has failed in those countries where they have been piloted. But all in all, we say that is a very good idea, because what the intention was for everybody to get healthcare, affordable healthcare, wherever they are, which has not happened. Because you'll find that in those counties, if you looked at Kisumu, where in the western region where it was piloted, the county had been promised that there would be reimbursements, especially the Linda Mama. There would be the continuous supply of essential and non-essential commodities. But all these collapsed completely. You'll find that if there's any county that has had a permanent strike from the health staff, it's those counties where the universal healthcare program was piloted. You take Kisumu, for instance, look at how many times months they have been on strike compared to counties where there was no piloting. So it was a way of assuring people that they will get healthcare in an affordable way in their facilities, but eventually we could not even provide essential commodities to these facilities. We had not enough health personnel. We had not enough infrastructure in these places. So it was a very good idea, but which could not work. Because you look at even the NHIF, which was very simple to manage, it's no longer working. You'll find that they are withdrawing some beneficiaries now. They say that certain category of beneficiaries are not supposed to be benefit from NHIF. they're now looking for might be those, I don't know. So it's being restructured anyway. But what we are seeing also, NHIF is coming down, just the way KEMSA has come down. KEMSA has not been able to provide commodities to and drugs to most of these counties which are piloting universal health care. Even the health personnel that were recruited by the national government to come and supplement the personnel that the county governments had, most of their contracts have ended. So just putting those counties in a crisis. So it was a very good idea, but there was no implementation plan. Even the financial implications had not been discussed. Even the provision of the medical equipment the medical equipment. Yes, these were given to counties, but you will find us as a governor, a very big machine has been thrown outside your hospital. Whoever brought it, you don't even have the personnel to operate those machines. You have to go around. Some hospitals up to now don't have personnel to operate these machines. But it's an assumption that we have this machine in this, so that people are now getting treated, diagnosed, which is not the case. This equipment, some of them are just going to waste. The cost implication, like this one for cleaning the kidneys, I don't know what it's called, this machine. The dialysis machines. It's very expensive to maintain them. Just getting the personnel and also the other instruments associated with it is quite costly to the extent that counties cannot run them. They needed some financial support and backing. Also, this equipment were brought, the prices were so much exaggerated. We started paying small installments that they increased the installments without even consultation. So mine just in the closing remarks is that for us to have a vibrant health sector, or if you have to deliver services properly, the most important thing is to unbundle the health sector, cost it, and know exactly how much is required in every county or every facility to deliver services to the people. In so doing, we should be being realistic. Thank you.
Thank you so much, Governor Ojamong, and thank you also for joining us this morning stroke afternoon. Really have enjoyed your participation and your insights, and we look forward to continuous engagement with yourself and Busia County in these very critical discussions on access to healthcare services for the people of this country. So thank you so much for your participation today. I think we can now move to Dr. Langat. I think you've been following the discussion that we have been having around corruption in healthcare and provision of healthcare services. And from the perspective of AMREF as a citizen of this country and also a healthcare user from time to time, as well as having understood what the health sector is, how would you critique the government's response to the COVID-19 pandemic? Do you think that the government did well? And if so, where did they do well? And if you feel they did poorly, where did they do poorly?
Well, thank you very much, Narima, for that question. And maybe before I move into answering the question, I'm a medical doctor, and I've heard from the governor and quite a number of people speaking about the healthcare workers, and probably I just wanted to, the healthcare workers that we have in Kenya, these are Kenyans, and we are not going to get it from any other country. It is the people, it is our relatives, it is our friends, and sometimes there's a lot of bashing of healthcare workers. They are stealing medicine. They have this duality in terms of practice. You are in public and yet you are also having the private practice, which is not much different from what goes on in other professions. So I think for me, what is critical is really to understand what is ailing the healthcare professionals. We don't necessarily condemning them also, because repeatedly, whether you read in the papers, is quite demoralizing for the healthcare workers. And trust me, if you are working at night, when I used to practice, you are working at night, there's a mother who requires a cesarean section, and I just arrive and there's no sutures. A simple thing. It doesn't cost a lot of money, but then what an operation that I could do it in less than 30 minutes, and I'm very sure I've saved a mother and a child. I just have to write a referral note. So I think that is the context, really. Let's not condemn the healthcare workers. We really need to understand what is their work environment. What challenges do they have? How is their growth? You have stagnated in a position for several years and there's no promotion. We need to train them so that they can provide specialized services. So I think that for me, I wanted to clarify that let's not always quick to charge the healthcare workers. It is the one that we have, quite trained, highly skilled, but maybe we need to look at what are the issues around their work environment. Now, on the question of the COVID response, I also, in Ambref, I have the privilege of interacting with external stakeholders and also have a view of what is going on in other countries. And by and large, I think the government has responded well. I want to skip a score of 3. They have actually, if you look at it, they quickly develop a response plan. The infrastructure that we have, we quickly retool and we are able to do diagnosis because we had already invested in some of the PCR equipments. We really put in some epidemic containment measures. Yes, so I think by and large they have responded well. They recognized and brought in different stakeholders from the private sector, whether it's faith sector. So I think the challenge for the government is now the second part of it, which is the perception and the trust, which are creeping because of issues around corruption or the alleged corruption in KEMSA. And really that has really eroded the good work that probably the government from the beginning when the COVID response came in, and that trust becomes a big issue. So you hear people saying, "I wish of the numbers that are coming in." When you work at the back end, you actually see the numbers, and we know that the numbers speaks what it is. So you see, already we are questioning government, and it's because of really the question of trust. I know, of course, that even when we started the contradictory guidelines, you are telling people if you are stable, don't come to the hospital, and that we know that we have these people, the patients who are on chronic care. If you are an HIV patient, you need to go for your pickup and whatnot, and really you are being discouraged from coming to the hospitals. That also created negative. Outpatient visits went down. We couldn't find even the tuberculosis, for example. There was a huge drop in case finding, and even the monitoring of HIV patients became a bit of a challenge. So, but I think they did realize that, and working together with partners, they started correcting some of those contradictory circulars and even working together with the programs. I ran tuberculosis and HIV programs and malaria program, and I know that, and I think Ruth had already mentioned that we actually put in place risk mitigation measures that have managed to assist us in retaining our patients on care, whether they are given multi-month dispensing, working with the communities to even identify and refer cases, escorting the patient, delivering medicine at the community level. Yeah, so by and large, for me, is a fair score, and partners to recognize, and sometimes they reach out to us. What is it that you are doing because you want to share with other countries, and so globally, even in Africa, I think Kenya is, even if you look at the testing rate, is fairly on the higher side. Of course, not compared to South Africa with the resources that it have. So in brief, I think for me, we need to manage. If we must be seen to be responding to issues that injure trust, whether it is an alleged corruption or corruption, then quickly move in and close it out, so that we don't lose the trust of our population and our partners. Over to you, Nerima.
Thank you for that. Um, just to wrap up the conversation, I'd invite Agri to just paint an ideal picture for us. Now, what would that healthcare system you aspire for look like?
Thank you very much. And I think I'll draw my points. I draw my points from Governor's very well elaborated frustration, and I want to thank Governor Ojamong for being very honest about the frustration that they're having. And really, if you are to have a functional health system, it's something that has been preoccupation of many for many years, from 1978. The Alma Ata Declaration, which really defined what an ideal health system should be. A people-driven, people-centered health system that is primarily more focused on, prevention rather than cure. Is the ideal health system that builds on all the building blocks of a health system. Is very, very focused on prevention of disease rather than treatment of diseases. That is more focused on keeping people healthy rather than treating sick people. I think that would be the ideal health system. And there are all those tools, like Dr. Lagat said, that can be there, to support that. The human resource for health do not just need to be curative. When we were growing up, those of us who were privileged to have been born earlier, everybody who was born after the structural adjustment programs of 1980s, when the public health system was defunded grossly, because somebody else somewhere sat down and said, government has no business funding public services. Yet this is the most critical sector that actually ensures redistribution of resources. Because you realize that if a health system remains dysfunctional as it is now, it creates inequalities, because the poor people pay more for health than the richer people. That's an unfortunate scenario. Myself, I have a very elaborate medical cover, but my parents and my siblings and my cousins don't have the same privilege that I have. And sometimes our middle class people tend to be very comfortable with that. And Nerima said something critical at the beginning, that we are all in WhatsApp groups at any given point in time, when this WhatsApp groups for collection of funds for people who either need, surgeries, or people who need, to be paid for bills so that they can be released from hospitals. So we still end up paying for this dysfunctional health system. What if this system worked in ways that people focused on keeping everybody healthy, so that you have fewer people who get sick, and these people who get sick are actually treated all by government without pay? It's something that has happened in many countries. I think countries like Canada are very clear about that. And the health system is not, a functional health system is the cheapest thing than a dysfunctional health system. It's very expensive if you look at the terms of absolute numbers of the cost that it takes a government to take care of a dysfunctional people in a dysfunctional health system. So in as much as we have an opportunity here to have responsive policies that would focus more on preventing many people from getting sick, so that we have fewer people to treat, we have a policy that focuses more on curative. And the governor, basically elaborated what the UHC was supposed to be. The main investment in UHC, the financing was supposed to be a dual financing system, where they support procurement of commodities through KEMSA, and they employ health staff. And then there's the component that was supposed to be financed by NHIF. If you look at that arrangement, it is a curative focus health proposition. Because you only require NHIF when you're actually sick. You only require commodities from KEMSA when you are sick. You only require those medical officers when you're sick. Where was the investment in disease prevention? That would have been the most ideal, efficient investment for government. So an ideal health system is one that is focusing on disease prevention, that focuses on keeping people healthy, so that the few that get sick can now be financed, can be supported through a tax-financed arrangement, where hospitals are equipped, doctors are paid by government, and there's no arrangement in between. Because the moment you introduce a contributory scheme like NHIF, even if it is 100 shillings, there's somebody who is going to make a decision not to go to hospital because they cannot raise that 100 shillings. So it becomes a barrier inevitably, however low you think it is. So I think those are the things I would want to point out, that a functional health system is the cheapest thing to do. and we should let science help us. There's overwhelming evidence in terms of what would really work for us. Let that science work for us. And the people need to come out as well and voice what is desirable. I think the lacuna or the gap that exists, which is being taken over by this influence peddling actors in between that influence our policies, because there's no political engagement in health. Let us be politically engaged in health. Let us make it a development priorities. Let us make demands from our leadership so that they can invest in the right areas. Thank you.
Thank you so much, Agri. And I'd like to thank all our panelists. I think we've come to the end of our discussion. So to thank Honorable Ojamong, Dr. Ruth Marshall-Ibon, Agri Aluso, Dr. Bernard Langat, and Salima Njoki for the insightful, thought-provoking, and really a call to action to all Kenyans to think through the next time we're about to give to an mchanga or any contribution towards somebody else's healthcare services, which we know they need, to really think through, why are we not holding our government accountable for that service? Why are we collecting money for people to go to India when we have a government who we pay VAT, income tax, fuel levies, all manner of taxes to on a daily basis to live in this country, yet we're not seeing the public services that come from paying all these taxes. And we continue to be one of the highest tax nations in this world, yet we do not have the benefits of that taxation. We thank all our panelists for their contributions and for really enriching our discussion on healthcare, the right to the highest attainable standard of health, and the impact of corruption. And I'd also like to thank my co-moderator. Maybe I'll allow him to say thank you himself, but I'd like to thank my co-moderator from where I'm sitting, but I'll allow him to say thank you himself, and Kenyatta University School of Law, as well as the All Kenyan Moot competition for inviting us to have this discussion today. Thank you so much.
For the past 8 years, the All Kenyan Moot Court competition has been keen on pushing the conversation on human rights within the Kenyan context. Through conducting various moot court competitions centered around human rights issues happening in Kenya, we've been able to engage with various stakeholders and, most importantly, law students from across the various universities countrywide to steer human rights discussions among students. This year will not be any different. Even with the COVID-19 pandemic that has changed what would be the old order to what is the new normal, we will hold our conference and moot court competitions to push the conversation around health and corruption, with a key focus on the Article 43 right, its realization, government response to the COVID-19 pandemic, and the malignant cancer of corruption that has over the years crippled the Kenyan healthcare sector. Join us virtually from the 2nd to the 5th of June 2021 as we discuss the theme, Combating Corruption in the Attainment of the Highest Attainable Standard of Health.